limit where you spare the lens? This is the first question. The second question is, we saw that you were doing laser, and you did laser in the horizontal meridian. Don't you think that doing laser in the horizontal meridian will affect the pupillary reactions, and sometimes you find the mid-dilated pupil because of the long cilia?
So I begin with the second question. You are absolutely right. I try not to do too much laser in that 3 and 9 o'clock area. On the other hand, because I myself have seen in the days of macular rotation surgery, where we extensively did that during our first 100 cases, we very often got pupillary distortion and a wide, non-reacting mydriatic pupil. And then we did, in that area, we did exocryo. But nowadays I almost have abandoned cryo totally in these cases, and I do very little, well, this is little is relative, yeah? Very little laser spots in that area. Not 3-4 rows, but perhaps only two rows, or very not confluent. So during the last years, perhaps 5 years or so, I haven't seen any pupillary defect, that means complication by this, except for pain. Yeah, this causes pain if at the end of the surgery the anesthesiology is not that good. But I know this complication, but I think if you do it like I did in this case, so perhaps 4, 5, 6 spots in that area where you see the long ciliary arteries and nerves, then this complication will not come up. The first question, well, of course there is a limit. Number one, there is a limit due to the nature of retinal detachment. Usually young patients do not get retinal detachment. And if there are trauma cases, then you have to do something else. But in routine cases, patients who develop rectomatogenous retinal detachments are in the age where the presbyopia has already begun, so more than 45 or 60 years, or 50 years. And then we remove the lens without hesitation, without hesitating, in an age up more than 15. And below, if we discuss it with the patient. If it is a myopic patient, sometimes they have benefit from removing the lens, but you have to, of course, consider the other eye. But if they take contact lenses, then of course they would benefit. And we try to get along with buckle if the patients are in a younger age than 30 or 40. But when these patients get a retinal detachment, usually in more than 50% at least, they need a vitrectomy and not only a buckle. But aura dialysis after blunt trauma with a football or so, they can be treated quite good or extremely good using a buckle only, depending when they come. Yeah, when there is PVR, they need vitrectomy anyway, and then we don't hesitate. PVR in a child needs a vitrectomy. This is for sure.
Yes, thank you. Are you still using lens in the bag? Oh, sorry.
Oh yes, more. Yeah, this Tassignon lens. Oh yes.
So after a long, that was maybe 2 years ago. So we saw you implanting this lens after 2 years.
Yes.
From using this lens, the long-term results of these lenses. Are you happy?
I'm still so happy that I do it more and more. My colleague Tillman Eckert has also begun right now during the past 3 months, and I have experience of more than far more than 300 cases, 350 cases, around about almost every day I implant this lens. I'm still very, very happy because the centration is wonderful. They don't get, of course, a secondary cataract, and the eye looks perfect. And what is more important, you don't get synechia. And in cases of rubiosis iridis, no synechia will occur. This is fantastic for diabetic patients. However, these patients, to operate on these patients are difficult. The red reflex which you need for the posterior capsulotomy is poor. If it is existing, you need a special technique to do this posterior capsulotomy. You need an additional light in the anterior chamber. This is another talk or presentation, but we can discuss it in the afternoon perhaps.
There's another question. Hello?
Yeah.
Another question about
yeah, sure.
combined phaco technique. Do you modify the phaco technique in case of combining phaco with vitrectomy than the regular phaco? Like I usually like to do a smaller anterior rexis. I usually do posterior capsulectomy in the center to avoid later PCO. So do you modify your regular phaco or you just do the regular?
Did I get the question? Can you?
You asked about the posterior rexis after
Well, if I have a case operated elsewhere or so, or operated by myself with a standard posterior chamber lens, then I have a look at the end of the surgery or the beginning of the surgery if the posterior capsulotomy with a vitrectomy instrument is necessary, and then I do it. The only problem you have is then condensation if you use gas at the end of the surgery, but this can be managed quite well using visco material. But then I would not perform a rexis. I would perform a capsulotomy with a cutter. Did I get your question?
This was not my question.
Sorry.
My question was that do you make a smaller anterior rexis to avoid the lens jumping out of the bag?
Ah, now I see. No, my rexis size is almost so, or is not almost so. Not always my rexis size is what I wanted. I aim for a rexis size which covers the anterior part of the optic of the IOL well and round about 0.5 millimeter to 1 millimeter, 0.5 millimeter. But in highly myopes or even medium grade myopes, the lens is by the air tamponade or gas tamponade at the end of the surgery is decentrated, and then at the next day, although at the end of the surgery the situation is quite good, the anterior capsulotomy is covering the optic, the anterior part of the optic. Next day it's so that the capsule, the anterior capsule is behind the optic, and then you have a secondary cataract within weeks. Yeah, and it looks not so good. So we have solved this problem in using the Tassignon lens. I don't have any tricks. Did anyone get the question? Otherwise you have to repeat your question.
Yes, I mainly think about the astigmatism induced by bulging of silicon oil through the rexis, through the posterior rexis.
I have only one option for this: remove the silicon oil as soon as possible. That means after 3 months or so. Yeah.
Another question, Klaus. This is Ablatif. This is Siam.
Yeah. Hello.
You have just told us that you are doing almost all your cases of ligamentogenous retinal detachment with vitrectomy, except rarely you do a bucket, you said. Is that statement, you hold this on this statement all the time, that the majority of cases, 90% or so, your ligamentogenous retinal detachment are treated by vitrectomy? Did you abandon completely
the buckling technique except very rarely? Is that the situation now in your department? This is the first question.
Oh, let me first see. Can you?
Because normally 90% of cases or more are treated with buckling. Normally, this is what we are following.
Dr. Sinan, can you repeat the question, please? And raise your
Yes,
voice, please.
is Klaus Ecker now doing vitrectomy for all his ectomatogenic sanitary detachment cases? Almost all his cases treated with vitrectomy. Did he abandon the buckling techniques?
No, I did not abandon buckling. I do buckle when there's a very clear situation, when there is when I'm convinced that there's only one tear. I do buckle, of course, when there is mainly a tear with a surrounding retinal detachment. I don't do a laser treatment around a detachment. So I close the tear and then I do laser or I do cryo. But when there is more than one quadrant retinal detachment and the patient is above 50 or 55, then I go ahead and do vitrectomy.
The second question is, you said you don't need to do any satellite in the eye, which means that you clean very well the periphery.
I try to.
You assist yourself by using triamcinolone, right? By triamcinolone, you use this.
Again, I was not able to catch your
The
question.
question is, you are cleaning the periphery base of the or as much as possible. Do you have the assist? Do you use triamcinolone to be able to do that?
No, well, very rarely. In highly myopes, I use triamcinolone, but otherwise I don't do stain or coloring or try to improve the visibility with triamcinolone. No.
Regarding the case.
Now we are directed to the room 2. Professor Hassan, can you explain to the audience what is the situation now of your case?
Yes, this is the retina, and I did laser for the retinotomy. There are some bleeding at the edge of the retinotomy because the diaphragm was not working well, but it is minimal bleeding, and I will try to remove it while doing the silicone oil exchange. Now the retina is attached, the macula is on, and I will do a laser for 360 degrees because the incidence can we increase the laser a little bit. عالي laser شوي. And finally, I will put silicone oil, and as I said, I will put the cement. In these cases, there is no need to put the buckle, of course. And actually, I stopped putting buckle since many years, because at one time it said that they are essentially in cases of trauma, but when you shave the base properly and you perform clean vitrectomy laser, I think there is no need to put a buckle.
دكتور حسن ممكن اسالك انا محمود شيبان صباح الخير.
صباح النور يا محمود.
ممكن اسالك سؤال كده. Now you have filled the eye completely, almost completely with the PFCL لغايه surpassing the edge of the retinopathy.
Exactly.
Right. And now you're doing some indentation.
Yes.
Is there a technique for indentation in order to avoid some VLCL bubbles to sometimes they escape under the retinotomy خصوصا لما يكون في indentation. Is there a certain technique to avoid this يعني complication of having some bubbles of VLCL under the retina?
I think the use of the valves has decreased the turbulence of the fluid inside the eye.
Yeah.
And this is very important because when there is much turbulence inside the eye, the VLCL bubble, how can we increase it? Okay, infusion الشريان كويس. And this breaking of the main PFCL bubble invites the smaller bubble to go under the retina even through small breaks. So I think that these valves are very advantageous. Also, when you do scleral indentation, do not increase the level of the perfluorocarbon to the level of the break, except when you have achieved complete relief of traction. Because once there is traction, you will get PFCL under the retina. So the use of the valve system, the relief of traction, also the presence of residual vitreous invites breaking of the main PFCL bubble into smaller bubbles. And really the use of good quality PFCL also. Right?